our goal in caring for these patients? Well, if it really kind of looks at time frame, in that first 24 hours from the time of our stroke, our goal is usually preserving life, keeping them alive, seeing the extent of that stroke. Because not all of these can we treat. If we have a patient that comes in with an ischemic stroke outside of the window for TPA, which is a thrombolytic, then all we can do is treat them symptomatically. Whatever they present with symptom-wise is what we can treat. And so for that first 24 hours, until we know the extent of the stroke or the extent of the swelling that's going to occur, these patients may deteriorate on us. They may get worse in front of our eyes as we are sitting there caring for them. So many times it's preserving life. It's preserving brain function, preventing further damage. And how do we prevent that? We just talked about several ways. Meds is a big way that we prevent further damage. Craniotomies, removing that skull, removing hematomas, are all big ways that we prevent further damage to brain tissue. We're trying to preserve the brain that they still have there. And then kind of after that 24 hours, we start looking at reducing their disability. What can we do to get them to an optimal level of function? What can we do to hopefully get them back where they are independent and caring for themselves? My aunt is in her 50s now, but in her 20s, she fell off of a horse and had a right hemispheric stroke. The carotid artery in her neck separated from the trauma, and she had a massive right hemispheric stroke. She spent 2 weeks in an ICU, and the day that my dad got her out of the hospital, she could not hold her head up. She was in her 20s and she drooled. She had no head control. She had no posture control. We had to put her in the van and tape her to the seat to keep her from falling out of the seat to take her to rehab. She spent months in rehab, and she came out of rehab and finished, well, she was a CPA. She was done with school, so she's probably late 20s. Done with school. Lost her job as a CPA with the firm that she was with, and she still now lives on her own and does taxes on a yearly basis out of her home office. So we can get them to a level of function. Now, she was a right hemispheric stroke, so which side of her body was affected? Left. So she has a left arm that is drawn, and she walks from the hip. And many times what you see is you'll actually see a motion of a throw of the hip. They'll throw that leg because they have function in the hip, but they lose they have the weakness in the leg. So they'll put it looks like a brace. Hers is clear, and it goes under her foot and up the back of her leg, and it straps to her leg. It keeps her foot flexed so that when she's throwing her hip, her toe doesn't drag the ground and she doesn't trip. And so she walks, and many times you'll see those patients walk with kind of a hip throw that they do, and hers is pretty significant. But she walks, she drives, she works as a CPA. Why do you think she can still work as a CPA? Because it was in the right hemisphere of the brain. Where do we deal with numbers? The left hemisphere of the brain. Now, she makes some bonehead moves. Like, my dad will get off the phone with her. It's his younger sister. She's 10 years younger than my dad. And he'll get off the phone, and he is so mad. He's like, "You will not believe what Jan has done now." And I'm like, "But I will. Why will I believe what Jan's done now? She's had a right hemispheric stroke, so what did we lose? Judgment. She is that irrational. She'll make stupid mistakes. She doesn't think. She flies off the seat of her pants. That is that process that she has developed because of that right hemispheric stroke. It frustrates my dad on a daily basis. And I'll be like, "Dad, she's had a right hemispheric stroke. We would anticipate this. She is that reckless, carefree type." Like I said, she makes some bonehead moves. But she's still able to live independently. She uses one hand. And so I joke all the time because she doesn't own a single knife in her house. Not a single one. Because it takes 2 hands to use a knife. You hold with one and you cut with the other. She can't do that. She has pizza cutters. So if you want to cut something up in her house, you better look for the pizza cutter because it's on a roller. And so she keeps one in her purse. She's going out to eat at 50 years old. She don't want to walk over to somebody and say, hey, can you cut my meat up on my plate for me so I can eat? She pulls her pizza cutter out. She cuts her food up. She wipes it off on her napkin and shoves it back in her purse. And when she gets home, she puts it in the dishwasher. So she's independent enough. So we have to kind of think outside of that box of traditionally eating as to what we do. When she had her stroke 30 years ago, people didn't drink with cups that had handles. Everything she drank out of was a coffee cup because it was something she could control. They do much better with handles. So she could control a coffee cup. It had a handle. And she hated it. She didn't want to be 20 years old and look different than everybody else drinking out of a coffee cup. Tervis tumblers came around and they had the handles that you could put on them. And she was like, thank God everybody else is drinking out of a cup with a handle. I look normal again. Because she had gone from drinking out of a coffee cup to now she walks around with whatever cup has the handle on it that she can drink out of. So we want to get them to that optimal level of function. We want to reduce that disability. That can be intense therapy. Now, do they regain the brain tissue that has died and they've lost from the stroke? No. So how do they get this optimal function, or how do we reduce disability then? How does that happen if that tissue is dead? Well, we have areas of the brain that will pick it up, and we also have muscle memory, the repetitive use of the muscles doing it. You hear muscle memory talked about a lot in sports. It's that repetitive use. The muscles themselves actually kind of learn that motion without kind of that brain telling them to do it. So there's other areas that will pick up tissue or brain tissue near the area that's damaged that will sometimes pick up the function of that area of the brain. And a lot of repetitive movement, we will get muscle memory that helps with that as well. A big one is for them not to lose function, not to lose, like, for instance, Jan, her arm is now drawn, her fingers are now drawn, and she's 30 years post-stroke now. But for years and years and years, she could take her right hand and straighten out her left arm. She could take her right hand and she could straighten out her fingers, and she could stretch her fingers. And she had that range of motion, she just didn't have the use of it. Now, she can still straighten her arm, but she's about here, and those fingers no longer come all the way out. But again, over time, she has just lost some of that function or that range of motion. So trying to keep them from losing that range of motion, especially patients that are profoundly devastated by this stroke, if they lose that range of motion, then we start seeing infection, especially when we talk about cleaning them. If somebody is having to clean them and they lose range of motion, and we'll talk about it again with spinal cord injuries, with hips especially, and we can't get them cleaned, we can't move their legs to get them cleaned, then we start seeing infections in the patients. So we want to reduce a disability and make them as independent as possible is our goal as they discharge from our facility. But initially, patient comes in having a stroke. It is always airway, breathing, circulation. Do they have an airway? Are they breathing? And do they have a pulse? Most of the time with a stroke, the answer is yes, they have those things. There are instances that the patient may not come in and controlling an airway, and we need to intubate them when they're having a stroke. But it's airway, breathing, circulation. We do remove anything that they can aspirate on, including dentures. We put them on an NPO status. They do not get anything to eat or drink by mouth because of the risk of aspiration. We do start IVs on them. Do they need large fluid volume? Does a stroke patient lose volume?
No.
No. Even when they have an intracranial pressure and they have a head bleed, that is not a significant amount of volume that they need fluid boluses. It's enough to cause intracranial pressure, but it's not enough to drop their vascular volume. So we start IVs on them. We'll give them some maintenance fluids typically, but not a whole lot. We will control blood pressure. Now remember, we want them slightly hypertensive, and most of them will come in, especially our ischemic strokes, that will come in hypertensive. Remove any constrictive clothing. We go to CAT scan immediately. And then we elevate the head of their bed if they're not experiencing shock. We elevate the head of their bed about 30 degrees, and we put them in a neutral midline position. We want that head midline and neutral 30 degrees. That promotes blood flow and return from the brain. We don't want that head flopped over to the side. We don't want them in an odd position. We want them 30 degrees in a nice neutral position at the neck. We'll also put these patients on seizure precautions because there is an injury to the brain, and we're going to talk about seizure precautions because we put almost all of our neuro patients on seizure precautions. If there's any injury to the brain whatsoever, they have the potential of a seizure, so they go on seizure precautions. With seizure precautions, does that mean the patient can't get out of bed? How many of y'all work on the floor? Patients on seizure precautions, can they get out of bed? Yes. What do we have to have with them when they get out of bed? Assistance. That's it. Just because they're on seizure precautions doesn't mean the patient can't get out of the bed. It just means that somebody needs to be with them. So we put these patients on seizure precautions. If they're up, we need to make sure somebody is with them. We are monitoring, again, blood pressure. If they receive a thrombolytic because of the ischemic stroke, then we are going to watch for bleeding of the patient. Because one of the risk factors of giving a thrombolytic, a clot buster, is the patient bleeds. And so we can actually have, when we have reperfusion of the brain, we can have bleeding that occurs, and we can have then a hemorrhagic stroke on top of the ischemia. We don't typically have a lot of fluid and electrolyte shifting with stroke patients, but we just want to make sure they're hydrated. Neurological assessments. This is a big one. And I can tell we haven't covered Module C when I read head to toe assessments, because neurological assessments is a big one that we cover with Module C. So when we talk about the neurological assessment of the patient, what are some things that we are actually assessing? Do what? Okay, pupils. What are we looking at with pupils? If they're reactive to light, if they're equal in size and even shape, size and shape, reactive to light, and if they are able to accommodate or follow commands, can they accommodate? All right, what else besides pupils are we looking for when we talk about a neuro assessment? Level of consciousness. Are they alert? Are they oriented? A patient can be awake and be disoriented. They may be drowsy but oriented. So we have different versions of that. You may have to shake them to wake them up. That doesn't mean they're alert. That means they're rousable, but they can still be oriented. They can be disoriented to place, and place is a big one to be disoriented to. That's very common because many times they have some type of memory loss from the event and may not remember what has happened, or that they've traveled from an outlying area, or they've been in an ambulance from another facility. So especially with our older patients, for them to be confused about location is not uncommon. They may think they're still at home, or they may think that they're in the nursing home when they're actually in the hospital. Many times you can reorient them and then ask them again, and they can tell you they're in the hospital. So with location, I'm not overly concerned when a patient is confused about location. We have patients all the time that get flown in, and when they get flown in, they started off in Florida, and they end up in Alabama, and you say, do you know where you are? And they tell you they're in a hospital in Florida. Well, they probably think they're in Florida. But so that's not overly concerning. But we want to know if they're alert, if they're arousable, if they are oriented. We want to know their pupils. Let's talk about the patient that is not alert and oriented. We can use several things to assess those. One is a GCS score. We use a Glasgow-Coma scale quite a bit. It's a 15-point scale that we use, and it lets us know essentially the level of function of the patient. You do not have to know the GCS scale. You just have to be aware of how it's used. It will ask, one of the questions is, do they open their eyes spontaneously? And it's either, you get like 4 points if they open them spontaneously, it's 3 points if you have to call their name, it's 2 points if you have to arouse them, and it's on a point system is how it works. 15 is the highest on a GCS score. They say you're brain dead at 8. I've seen patients that have scores of 4. They don't have great outcomes, but yeah. So it's that 15-point range. Most patients with strokes usually fall somewhere between 13 and 15 on a GCS score. What if the patient doesn't respond to you calling their name? Then what do? We stimulate them. How are we going to stimulate them? I would like for you to tap the shoulder first. Like, I might come up swinging if you decided to pinch me because I'm asleep. Just if I'm don't respond to voice, tap me first. Dr. Neal, are you awake? And then if I don't respond to you tapping me or speaking loud, then we can start looking at painful stimuli. Let's talk about painful stimuli for a minute, because you're going to see a lot of it done wrong and a lot of it done right, and we want to identify the difference. A patient who does not respond to a verbal or a touch, and we're going to apply painful stimuli, what do you think we're going to use? We tend to see sternal rubbing done quite a bit, and I'm going to talk about the pros and cons to sternal rubbing. Sternal rubbing is accepted. It's not my favorite, but we'll talk about it. What else can we use? Nail beds. So pressure on nail beds. So grab your pen, because we all typically have a pair of scissors or a pen with us in our pocket when we're at the hospital, right? And put your thumb on the back side of your finger and put your pen in the nail bed of that finger, and just apply just a little bit of pressure. Doesn't take a whole lot, just a little bit of pressure, and you get some pain, right? It doesn't take much to put some pressure on a nail bed. Working for you? Doesn't take much. That is a painful stimuli, and when you press on that nail bed, are you causing damage? No. It just happens to be a tender point. We also have trapezius muscle here at the neck. You can squeeze. We also have right here at the armpit. You have a tendon that you can get a hold of. Squeezing all of those are not causing injury to the patient. Now, it causes pain, but it pain our intent. Yes. All right, so they respond to pain. What is it? Somebody charts. Patient responds to painful stimuli. What did that tell you? Nothing. How did they respond to a painful stimuli? Because there's lots of ways to respond to a painful stimuli. There's appropriate and inappropriate ways to respond to a painful stimuli. You provide a painful stimuli and they reach over and try to slap your hand, guess what? That was appropriate, right? That is location. They are locating toward that pain. You apply a painful stimuli and the arms draw and the toes point. What have we got? It's not. What kind of? It is posturing. What kind? Toes will point and arms will draw in. You're right. Keep going. This is decorticate posturing. We're protecting the core, decorticate posturing. This is a higher level of function than this, which is decerebrate posturing, when the arms roll out. When the patient, and you think about it like humanistically, if you think about the patient no longer protecting the core of their body, like they're vulnerable. That is that decortic or that decerebrate posturing. So when we start talking about painful stimuli, I need to know what they're doing with a painful stimuli. If they are trying to withdraw from a painful stimuli, that's appropriate. But if they're posturing, that's inappropriate. Or if you start getting movement in a leg and you're squeezing the trapezius muscle, that is an inappropriate response to pain. Let's go back to sternal rubbing. Patient's laying supine, so they're laying on their back 30 degrees. They're intubated, and what do we do with their arms when we intubate them? We restrain them. So their arms are down by their side so they don't pull their tube out, and we are going to go check for a painful response. And the first thing we do is we reach over that patient and we put our knuckles on their sternum and we start rubbing. All right? Think about the skin at the sternum. Not very thick. It's actually a very thin part of tissue of the body. Sternum has ridges, and we have knuckles, and we start rubbing our knuckles over those ridges. They're getting neuro checks every hour for the next 2 days. For the next 48 hours, somebody goes in and rubs that sternum. What's happening to the tissue on the chest? We're breaking it down. As a matter of fact, I took care of a neuro patient who we had sternal rubbed to the point that the skin broke down, the sternum got infected, and we had to remove the patient's sternum because we had sternal rubbed the patient for neuro checks.
I see a doctors come through that all the time.
Sternal rubbings are accepted. That's okay. We can sternal rub, but did we just cause harm to the patient because we were just trying to find out what their neurological status was? That is assault. Like, in the court of law, we have caused damage to the patient, injury to the patient that should not have occurred. So that's why we go to different areas. That's why we use nail beds. That's why we use the trapezius. That's why we use the armpit. We can use the sternal rubbing. Can we pinch nipples or scrotums? No. You laugh?
Someone's done it.
There are lots of people that do it.
Not stroke.
Someone's done it.
Oh yeah, all the time.
All the time.
They jump out the
Yeah. And the problem with that is it's not accepted form of painful stimuli. It causes damage to thin tissue. You have lots of nerve endings there, but you also have mammary glands. You also have different lymphatic systems that don't need to be disturbed or hurt, and it's assault. Patient comes in with bruises on their chest. Should we ever leave bruises on a patient from checking for painful stimuli? No. That's not our purpose. Our goal is not to leave bruises on them. Our goal is to see if they respond to pain, because we have a decreased level of neurological function. And so we have to provide a painful stimuli, but it's not to injure the patient. So be mindful of the sternum, because we can cause injury. But then the patient does this. They're laying on their back, you sternal rub them, and you get this. What response was that? Was it appropriate?
Yeah.
Was it inappropriate? How do you know? How do you know? You're on top of them. You've put your body between your body and the frame. You have not given them opportunity to move away from it, which is withdrawal, because you're on their sternum. So can they move away from it? No. So you have just negated the fact of, is it an appropriate or inappropriate response, because you can't tell withdrawal with a sternal rub. So why cause pain to the chest if we can't get the true response we want from it? That's why many times what you see is the nurse, hopefully you see, is the nurse go to all 4 extremities and apply pressure to nail beds. Why all 4 extremities? To see if there's a weakness difference in extremities, or if they've had a right hemispheric stroke, guess what? They may not have anything on that left side. They may not move anything, and you keep pressing the nail beds on the left side of their body going, nope, there's no response to pain.
I was going to ask that, because when I was at the ER my first time, and we had a stroke patient come in, and it was on his right side. And
His
so,
right hemisphere, or he
No.
was weak on his
He
right
was
side?
weak on his
So
right
his
side.
stroke was not on his right side.
Right.
His
Sorry.
stroke was on his left
Left
side.
side.
Okay, so he was a left hemispheric stroke.
Mhm. And so
His weakness was on his right
we
side.
had the neurological consult, he's on
Monitor.
the monitor or whatever. He had us break the swabs and do all the extremities, poke with the broken end of the swab,
Mhm.
testing for painful stimuli that way. But I mean, is that like typical? I
Yeah,
have never
all
seen-
4 extremities.
Yeah, the all four extremities part, but I mean, I guess that's
It's
just
just something,
using a
it
different
was just something
form.
sharp. Yeah, it was just something different. Yeah. But yeah, all 4 extremities, because they may not be able to move one versus the other. And you put a painful stimuli on the side that they're flaccid on and they don't move it, well, then you're getting false data, if that makes sense. So that's why you should go to all 4 extremities, and why they typically go to the extremities instead of to the chest of the patient. Because you can get how weak they are. Like I start doing a pressing on a nail bed on the left side, and they move that left arm quickly. I do it on the right side, and I get just a little bit of a movement to it. I know that they're feeling it, but they're much weaker on one side than the other of the patient. So think about what you're using for your painful stimuli, not only because we can cause injury to the patient, but then what are we wanting as a response? If I'm not going to get a withdrawal on the patient, then do I need to use it as the form of painful stimuli if the patient's been withdrawing? I don't need to do a sternal rub on that patient if they've been withdrawing from the hands, because I need to know if they withdraw, and you can't withdraw from a sternal rub. You can't really tell if many times you can't tell if they're posturing with a sternal rub. You might get a facial grimace, and yes, we realize that that's pain, and they are responding to a painful stimuli, but we're not really getting what they're doing with that. So just be mindful of the sternal rubs. We see it all the time, and we cannot pinch nipples and scrotums. I'm telling you, they can file lawsuits against you. You can lose your license. You can lose your job. You can lose 2 years of school. I mean, wouldn't it stink to work this hard to have a nursing license and somebody take it away from you because you pinched them as a neuro check? So just be mindful of that with patients. You will see it. It is wrong. Don't do it. Strokes, patients, and this is one of the reasons that we do workups, cardiac workups as well, is patients that have strokes are more likely to have strokes, and patients that have strokes are likely to have seizures. That's why we put them on seizure precautions as well. We will typically see patients that have had a stroke will have a reoccurring stroke within a year. Kind of interesting, the facts on strokes and reoccurrence. Drugs. We haven't talked about drugs a whole lot yet, so let's talk about them for a minute. Calcium channel blockers. We use calcium channel blockers on strokes, not necessarily for hypertension. We use calcium channel blockers to prevent vasospasms. So the patient who is hypertensive and has had a stroke, and they add a calcium channel blocker to them, patient's pressure is a little low that day, and they have 2 medications. They have a beta blocker and a calcium channel blocker. Are we going to hold the calcium channel blocker? No, we're going to hold the beta blocker because we're not giving the calcium channel blocker for pressure. Yes, does it affect pressure? It does, but we're giving it because it is a calcium channel blocker to prevent vasospasm, because it prevents vascular vasospasms or cerebral vasospasms. So we use it in stroke patients, especially post-aneurysm clippings, to prevent vasospasms. So I would hold any of my other blood pressure medicines before I held my calcium channel blocker. I would have to call and verify that they truly wanted me to hold a calcium channel blocker. I wouldn't hold it. Only because we're using it to prevent spasms. Mannitol. We talked about mannitol earlier to decrease intracranial pressure because it is an osmotic diuretic. Mannitol. What do you know about administering mannitol? Anything? Has to be filtered, has to be given through a filter, and it will crystallize almost at room temperature. So mannitol can be tricky in the fact of sometimes you can draw it out of you can get it out of your machine and it actually has crystals in it. You'll actually have to warm it in your hands, roll it before you can actually put it on a filter and give it to the patient. Diuretics. We can give mannitol, and then we can follow it with a loop diuretic like Lasix. Why can we do that with the patient having a stroke, but we don't do that with the patient that's burned?
Because the burn patient needs fluid resuscitation.
Okay, the burn patient needs fluid resuscitation. What about the stroke patient? Is their vascular volume low? It's not. So they are fluid neutral with strokes. So they can handle being just a little dry with us using a diuretic to get down that intracranial pressure. And as a matter of fact, if a patient does have an increased intracranial pressure, they will stay on the dry side. We will keep them just a little dry, vascularly dry, so that we don't have that swelling occurring in the brain. So many times you will see mannitol in combination with Lasix. They'll give mannitol and then followed by a loop diuretic. That's so that the mannitol draws it out of the interstitial space, puts it in the vascular space, and the loop diuretic draws it out of the vascular volume and causes us to urinate the extra volume out. Anticonvulsants. We use Dilantin, we use phenobarbital, we use all kinds. Keppra is a big one that we use. Keppra, the great thing about Keppra is it's a piggyback. You can hang it and let it run through a pump. There's no cardiac considerations with it. That's not the thing. That's not the case with Dilantin. Dilantin causes cardiac dysrhythmias when you push Dilantin. So Dilantin, if you're giving a loading dose of Dilantin typically is given as a loading dose and then an infusion. If you're giving a loading dose of Dilantin, you have to have the patient on a cardiac monitor, and you have to be at bedside pushing that drug by hand. It can't go on a pump, not that loading dose, because they start having ectopy with Dilantin. I have sat at bedside sometimes 20 minutes giving my loading dose of Dilantin. It's tried and true. It's an old drug. It's been used a long time. Works very well. But that loading dose can be a little tricky with cardiac.
So what's the difference between that and Keppra? Like, why would you not just give Keppra?
Sometimes it's physician preference. Sometimes you see Dilantin work a little faster with a loading dose than you see Keppra work. But many times it's preference, and if they have already had a seizure. If they've already had the seizure, you're probably going to see Dilantin, whereas if we're just preventing seizures, you're probably going to see Keppra. There's that delay in action. Patient develops fevers, we can use acetaminophen. We put patients that have had ischemic strokes on aspirin. Remember, they've had some type of blockage, so we put them on aspirin. And if they meet our time frame for a thrombolytic, they will get TPA. TPA is given to our ischemic strokes, not our hemorrhagic strokes. The American Stroke Association says that we have to give TPA within 3 hours of the onset of symptoms. Now, our facilities will push that out, and they are. Guidelines, you're seeing facilities that will use 4 hours. You're even seeing some that will use 6. Let's talk about the risk of giving TPA after that 3-hour mark. So TPA is a thrombolytic. The patient has a clot blocking that artery. We give them the thrombolytic, it busts that clot up. I felt that coming on. It busts that clot up, and we reperfuse the brain, and hopefully we stop the stroke process and they regain some function. That is the goal of TPA. When we give TPA, the further out we give TPA, the more likely they are to have a head bleed. And the reason being is this. We have a vessel and all this brain tissue distal to it. The vessel becomes blocked. We give TPA. and we open up that vessel. Now, for the time that they've been having this stroke, what we have had going on distally, because that tissue has not been getting blood, is we've had ischemia occurring. So that tissue starts dying. Well, we then give them TPA, we reperfuse that area. It is now getting blood flow, but what happens is this tissue that it has started dying doesn't have the integrity to hold that blood, and we develop a bleed. And so now they're bleeding out instead of just reperfusing. Does that make sense? So the risk of giving TPA is a bleed, and that risk exponentially increases the longer we're out from the beginning of the stroke, from the onset of the stroke-like symptoms. So that's why the American Stroke Association says 3 hours. 3 hours is as long as that tissue is viable enough to be reperfused. Even at 3 hours, you can still have patients that develop head bleeds. And we take care of a lot of patients that receive TPA and still develop head bleeds, even within that 3 hours. So if we push it out to 4 hours or we push it out to 6 hours and we're still giving TPA, guess what? That risk for bleeding, it increases big time as we move further out. So right now, the American Stroke Association says within 3 hours of the onset of symptoms, we can give TPA. Not 3 hours from their arrival to the ER. 3 hours from the onset of symptoms. So we have to know what their last known well time or the time their stroke began is. And many times you'll hear physicians say, when was the last time they were well? Or when was the last time they were normal? Or when was the last time, that is the time you have to go off of. Unless the patient can say, I was sitting at the breakfast table, it was 8:15, and I was eating my cereal, and I ate my first bite, and when I went to pick up my spoon for my second bite, the spoon fell out of my hand, and my hand was weak. And they know at 8:15, that's when their arms became weak. That is the onset of their symptoms. Now, did they wait at home until 9:15 decide to come to the ER? Or at 8:15 did they realize that that was a stroke symptom, that they were having arm weakness, and they got up and they called somebody and they came and got them? That is why we use that FAST poster. We're using those logos, those sayings, so that we can get people aware of those symptoms. If they're asking family, they'll ask about last known well time. When was the last time that they were well? If they say last night at 8 o'clock, guess what? They're not within their window of TPA because we don't know when that stroke occurred in the last 12 hours. We looked at aneurysm clipping earlier. Coiling is another one. Coiling, we looked at clipping. Wrapping is how we can fix a fissure-form aneurysm. So now, clipping we can use with sacral or berry aneurysms. Coiling we can use with those as well. But fissure-form, remember, it balloons out on all the way around the vessel. So the only way we can basically reinforce that vessel is to wrap the vessel, and it's how you fix a fissure-form aneurysm. I have not seen a fissure-form aneurysm wrapped. All I've ever seen is coiling and clippings, and maybe it's just because fissure-form aneurysms are not as common, or maybe they just, when I've seen them, they've all been ruptured. They weren't as a preventative. We looked at a coiling video earlier. When we talk about the size of the coil, that coil in size is actually smaller than a single strand of hair. They are super thin coils, so they may use multiple coils. They'll also use coils that have different shapes. So depending on the shape of the aneurysm is the shape of the coil they'll use because they want it to match in shape. We're doing a lot of thrombectomies right now, and that is where we just actually go in and remove the clot itself. If a patient is not a candidate for TPA, many times they'll try to remove that clot. They'll do the thrombectomy. Guess what? One of the risk factors of doing a thrombectomy is bleeding. Absolutely. We reperfuse tissue that can't handle being reperfused, and we have to worry about them bleeding. But they'll go in, if they are able to, they will deflate a balloon distal to the clot, and then they will use what looks like a corkscrew to kind of grab the clot and pull it back, and they vacuum with it, or they vacuum it out, trying to keep them from having another stroke, and then they'll deflate the balloon. When we look at patients that have had strokes, we talk about arms and legs being weak, but don't forget it affects the core of the body as well. So not only will they be weak in their left arm and their left leg, they will lose those postural control muscles as well, those abdominal muscles, the back muscles that help them stay upright. So you can't take a patient, especially these little elderly patients that's had a stroke, and put them in a chair and expect them to stay. They will fall right on out of a chair. So if you're going to put them in a chair, make sure they're in a reclined type position, because they will absolutely just kind of slinky out of that chair because they have that poor postural control of that side of their body. In the video, he mentioned that they would have, with right hemispheric strokes, they would have left-sided neglect. There's several different versions of that, but most common is that left-sided neglect with right hemispheric strokes. It's where they lose that visual field and don't see anything to the left side of the midline. We typically as nurses pick up on that first with things like they're not eating anything on the left side of their plate, or you've got their belongings on the left side of their body and they want you to find their phone for them. And it's on the left side and they can't see it, or it's on the table. You move it to the right side and they can find it. I took care of a patient one time that had left-sided neglect, and the room door was on the left side of the patient. So guess what? He didn't acknowledge anybody that came in that room and talked to him until they got past the foot of his bed and moved to his right side of his body. Now, do they ever regain that? They do not, but we can teach them over time to scan their environment and to how to compensate for that left-sided neglect. We don't do that initially. We don't go, well, tough, I'm leaving your phone on your left side, you got to figure out where it is. Initially, we move everything to that right visual field for them so that they can find it. We then, probably after discharge and with therapy, will teach them how to overcome that left-sided neglect so that they identify that it's there. I had a student whose father had a stroke and had left-sided neglect, and he would tell him, I know that you're there and I can't see you, but there's still, it's kind of like that absence. He still feels like there's something missing there. He said even years after his stroke, he scans and he overcomes it, but he still has that neglect on that side. So they don't typically regain that visual field. What happens is they learn how to adapt to it. And when adapting, we want to make devices as easy as possible for these patients. Large handles and anything with handles they will always do better with than things without handles. Styrofoam cups are the worst. Why? They're flimsy, they're soft, there's not a handle to them, they don't have a good grip, and they drop them. So teacups, anything with a handle works much better. Coffee cups with a handle work much better for them. And then anything that they can use gross motor with and they don't have to use fine motor, they're going to do better with. So like these utensils in the top left, they've got large handles on them because they have that gross motor movement with them and not a fine motor. There's lots of utensils that you can actually Velcro onto the hands as well. And so then they only have to have wrist movement. They don't have to have finger movement in using them. Plates, anything that has a lip that they can scoop against will make them more independent because they can pick up their food on their own. So you just have to kind of think about what works best for them with devices. You may have to try several different things. Again, that's typically on the rehab side. We don't see a lot of that inpatient. Dietary may do a few things, but most of that's done on the rehab side. Like I mentioned, that first 12 to 24 hours, we are really trying to stabilize these patients. And then after that, we look to a rehab or an optimal level of function. Of course, we want to prevent future strokes. Like I mentioned earlier, if they have a stroke, they are more likely to have a second stroke within the first year of that stroke. So we want to prevent that next stroke. And how we prevent it? Many times it's changing diet, it's changing exercise, getting them on an exercise regimen, might be putting them on cholesterol medicine, controlling their diabetes, hypertension meds. It's getting those modifiable risk factors under control. If a patient is having TIAs and maybe has not had a stroke, carotid endarterectomies is another one that we may see done to prevent a future stroke. Many times the patient's carotid arteries are actually clogged, and so we'll go in and we'll remove the plaque out of those carotid arteries. Now, with carotid endarterectomies, or the removal of that plaque, we always do the worst side first. So you might have one carotid that's 75% blocked, and you might have the other one that's 90% blocked. We're going to do the carotid endarterectomy on the 90% occlusion first. They will wait about 6 to 8 weeks, and then they will come back and do the less occluded side. Because you have to clamp that artery off completely to do the carotid endarterectomy. You run the risk of the patient stroking during a carotid endarterectomy. So you want to provide them as much possible blood flow. So you always want to do the worst side first so that they still have that better side of blood flow while you're doing the carotid endarterectomy. This is a smoking commercial that never aired, that was deemed too graphic for TV, but it's a reenactment of a carotid endarterectomy.
This is the main artery to the brain. Smoking makes fatty deposits stick to its walls. If they stop blood flow to your brain, or if a piece breaks off, it can cause a stroke that can kill, blind, or paralyze. Not all smokers have strokes, but all smokers do have fatty deposits in their arteries that can cause a stroke at any time.
That plaque buildup, I don't know why I always thought of something more consistent like Jell-O. It is actually very fibrous. It has a very thick content to it. Will actually hold the shape of the artery even after they take it out of the artery. So with the carotid endarterectomy, they clamp above and below. They cut the vessel open, they remove that plaque, and so the vessel back up. It's a fairly straightforward procedure. Carotid endarterectomy should not take long. Like, there is a timer that starts when they clamp, and they know exactly how long that artery is clamped when they do carotids. I think we have surgeons in town that can do carotid endarterectomies in about 12 minutes.
I got to assist Pfeiffer in one of those, and it was super quick.
Yeah, they don't take long. 8 to about 12 or 15 minutes is all it should take to do a carotid endarterectomy. Because remember, you're cutting off blood flow to that brain while you're doing it. We can also stent arteries in the head, just like we can stent arteries around the heart as well. If it's not significant enough to remove, or it's not in a vessel that it can be removed, we can put stents in. Basically just kind of keeps that vessel dilated to improve blood flow. And that is the first part of neuro. We will pick back up on neuro on Tuesday. Dr. DeBose, I sent her a text about ATI. She has reopened them again, and she has called ATI to kind of find out why they keep